deletion of chromosome 13, or they have hypodiploidy on conventional cytogenetics, or they may have a very high labeling index. Any one of these features places the patient in the high-risk category. Those patients who have abnormalities such as hyperdiploidy, translocation 1114 or 614 or the like are in the standard risk group. Now, we look at the type of therapy depending upon the risk of that patient. And we first of all decide whether the patient is eligible for transplant or not. In Europe, it's rather easy in that if a patient is older than 65 years, they're not eligible for a transplant. Here we look more at the physiologic age of the patient rather than the chronologic age, and some of you may well have been transplanted above the age of 70 years. At the same time, there are patients in their 50s, for example, or 60s, who have other medical problems unrelated to the myeloma, such as bad heart disease or other medical problems that make transplant impossible. So, when we look at the patient who is transplant eligible, we look at the standard risk people, and again I want to emphasize that if possible a patient should enter a prospective randomized clinical trial. But if not feasible for one reason or another, we prefer 4 cycles of Revlimid or lenalidomide and dexamethasone given at weekly intervals, or a bortezomib-containing regimen. Bortezomib is Velcade. After 4 months of therapy, we collect the stem cells, and at that point, we recommend that the patient proceed with an autologous stem cell transplant. If the patient does not achieve a complete response or a very good partial response after the first transplant, we consider a second transplant, but many patients say that one's enough, and we stop at that point, and in general, we do not give maintenance therapy for these patients, and the patient goes about their business without any therapy whatsoever. The other option, for example, would be to continue Revlimid and dexamethasone, and just this last week I received a letter from a physician telling me that one of our very early patients who was started on the Revlimid dexamethasone program was beginning his 57th cycle. That would be 57 months of Revlimid dexamethasone and continuing to do well. For those patients who fall into the high-risk group, we recommend 4 to 6 cycles of bortezomib, that is Velcade, containing regimen, and there are a variety of regimens, CBD, cyclophosphamide, bortezomib, dexamethasone, Velcade, Revlimid, dexamethasone, Velcade, thalidomide, dexamethasone, any variety of them, and there have been no studies comparing these head-to-head, so yours is better than mine is better than the next fellow's, and so forth. But in reality, we don't know which is better than the other. If that patient in the high-risk group is not in a complete response, we would seriously consider an autologous stem cell transplant, and then after this, for these patients in the high-risk group, we would recommend maintenance therapy with Revlimid and weekly dexamethasone. Now, At least half of patients with multiple myeloma are ineligible for a transplant for one reason or another. First of all, half the patients with newly diagnosed multiple myeloma are older than 70 years of age. For the high-risk patient, we recommend melphalan prednisone plus Velcade. And if the patient is in the standard risk group, we recommend melphalan prednisone and thalidomide or Revlimid and dexamethasone, and then treat them to the point of maximum benefit. Now I'm going to go on and show you just a few studies that support what I have recommended in those initial slides. This is a study that was chaired by my colleague Vincent Rajkumar in the Eastern Cooperative Oncology Group, of which we are members. There were 445 patients with newly diagnosed multiple myeloma who were randomized to receive lenalidomide or Revlimid, standard dose of 25 milligrams for days 1 to 21 of each monthly cycle, and dexamethasone in the conventional dosage of 40 milligrams given days 1 to 4, 9 to 12, and 17 to 20. Or the patient was randomized to lenalidomide, the Revlimid, same dose, same schedule, plus dexamethasone given here, 40 milligrams at weekly intervals. And what did we find? Well, bottom line, survival, 96% for the weekly dexamethasone versus 88% for the conventional dose dexamethasone, and at 2 years, these differences were still present, 88% versus 78%, and of course the difference is due to the increased toxicity of the dexamethasone. There is another option. This is the so-called BIRD trial from Cornell University in New York, in which they did a phase 2 study using lenalidomide, Revlimid, same dose, same schedule, and dexamethasone given at weekly intervals, plus clarithromycin, which is Biaxin, which is an antibiotic.